This is Chapter 12 out of your Ward and History. This is the process of labor and birth. So, labor and birth process, there is 5 critical factors for the whole birthing process to take place. There's the powers. These are the physiologic forces. There's the passageway, that's the maternal pelvis. The passenger, which is the fetus, and the placenta. The passenger and the passageway relationship, and then psychosocial influences. So first we're going to talk about the powers. So this is the physiologic force of labor and birth. This includes uterine contractions, which is the primary force pushing that fetus out. And then the secondary force is the maternal pushing forces. So some characteristics of uterine contractions. So increment is where the contraction is building up. The acme is where it peaks, the contraction peaks, and then the decrement is where there is a decrease in the contraction. So after mom has a contraction, the uterus is going to return to the normal state of relaxation, and this kind of gives, it's our body's natural way of giving mom a break so she doesn't get so exhausted. Probably some of you who have had babies know how exhausting it can be. So we want to assess the contractions. We want to assess so the characteristics, like the frequency, like the beginning, that's the beginning of one contraction to the beginning of the next contraction. The duration is how long it goes on, and then the intensity. Is it mild, moderate? Is it a strong contraction? Then palpation. So this is where you're going to feel, you're going to put your hand on the fundus of the uterus and feel the contractions. Then there is electronic fetal monitoring. They'll do this with a tocodiameter externally, and that will help measure the contractions. So again, there's external and internal. I talked about the tocodiameter being the external, that's the non-invasive. And then there is an invasive one where it's an internal monitor. And they'll do an internal monitor if the membranes have already ruptured. So a couple terms we need to talk about. Effacement is where the cervix shortens and it thins out. It's expressed in percentages, and as the woman progresses in her labor, the percentage is going to be higher. Dilation is the opening enlargement of the cervix. It's expressed in centimeters. From 1 to 10, full dilation is 10 centimeters. So at 10 centimeters and fully effaced, baby should be coming out. So the powers. Again, with the maternal pushing effort, so the woman naturally is going to want to bear down, and that's just that pushing to try to get rid of the fetus. Again, it's using those abdominal muscles, which is why we talked about diastasis of the abdominal muscles and that tearing, and this is why, because the woman uses her abdominal muscles to push. So the women who have the stronger urge to push, usually do a better job than the women who don't really have those sensations of pressure. And the sensations can be, diminished with medications that we've talked about. So the passageway, the pelvis and the soft tissues, there is 4 types. So there is the gynecoid, which is like the normal female shape. There is the android, and this is where the pelvis is heart-shaped, more like the shape of a male pelvis. It's a little more narrow. The anthropoid is the ape-like, and the platypoid is like a flat oval. So the passenger, this is the fetus and the fetal membranes. So normally baby is going to present head first, but there could be times where baby is positioned wrong, and the feet or maybe presenting first. So the molding of the head. So the sutures and fontanelles it's pretty flexible in a fetal skull, and because of this flexibility, this allows like overlapping of the bones, and it helps baby come out easier. So fetal attitude, fetal lie, that is the relationship of the long axis of the woman to the long axis of the fetus. So, and then the attitude is the relationship of the fetus body parts from one to the other. So this is like the fetal position, how the baby is normally in a flexed position. So the presentation, that is what part of the fetus is going to be coming out of the birth canal first. So if it's cephalic, that means that the baby's head is coming out first. But there is different kinds of cephalic presentations. So there's vertex, and this is where the head is fully flexed. Then there is military, where the head is in neutral position. And then there's brow, where the head is extended. Or the baby can have face, where the head is fully extended, but the face is what's coming out first. So the advantages. So the head is usually the largest part of the infant. So when the head comes out and then the rest of baby can come out, it's easier on mom. Again, with that molding, the baby's head is flexible. And so the head can maneuver pretty well. If the baby comes out any other way, like breech, this is where the buttocks are coming out first. There is a few different kind of breeches. There is frank breech, where the legs are extended up and towards the shoulders. Kind of would be an uncomfortable position, so the buttocks are coming out first. Complete is it's essentially the same the baby is flexed with the buttocks presenting first, but it's the exact opposite of the cephalic presentation. And then there's the footling, where like one foot or both feet come out first. But the problem with the breech is that it puts mom and baby at risk. So there's an increased risk of umbilical cord prolapse. It's more of a difficult, prolonged labor. There's a lot more pain. Shoulder presentation. This is a transverse lie. It's pretty rare, but this is when like the shoulder is usually the first presenting part, but like the arm can come out, and baby kind of comes out on the side. But this presentation, it occurs more often with like preterm birth, premature ruptured membranes. So if baby is in this position, a C-section will be needed. Figure 12.8 on 364 shows kind of that shoulder presentation with that lie, and as you can see, it would be very difficult to get baby out safely, and so that is why a C-section will be needed, unless if the physician can get the fetus to rotate. So the passageway and passenger relationship. So engagement, that happens when the widest part of the fetal presenting part has passed through the pelvic inlet. So, and then the station refers to the level at which the presenting part is resting to the maternal spine. So if the ischial spine is at station 0, and then if it goes above that, that is a minus station, but if it goes below that, it's a plus station. So if the woman is at like a +4 station, that means that the presenting part, so like if the baby was in cephalic, that head will be right at the pelvic outlet. And then that presenting part, that head should descend right into the pelvis and right out of mom. So the position, there is 4 quadrants of the maternal pelvis, and so at the vertex position, that's at the occiput, that'll just be O. If it's the face, that'll be M. If it's breech, it'll be the sacrum. If it's the shoulder, that correlates with the acromion process, and that will be in A. So what they'll do is, for the landmarks of positioning, the abbreviations are used. So they'll use the first and last letter will be the maternal pelvis. And then the second, or that middle letter, will be the fetus's presenting parts. So, for example, if baby was positioned at the right occiput anterior, it's going to be ROA. So that first letter will correlate with the side. That middle letter will correlate with baby's presenting part, and then that last letter again, are they anterior or posterior? So, in looking at positioning, if the occiput is posterior and towards the back, wherever baby's at, it's going to have an impact on mom. So if it's towards the back, that can cause prolonged labor and back labor pains. So, psychosocial influences. Again, like critical factors is have mom and dad been to educational classes? Are they ready to have a baby? What are the cultural views of childbirth? Is it okay to have medications? Is it not? And then the transition facilitated by a positive childbirth experience or negative. Has mom had babies before, and has it been an awful experience for her, or has it been a good experience for her? So some signs and symptoms of impending labor. So lightening, this usually happens at about 38 weeks. So this is where the presenting part, it kind of settles and goes down into that pelvic cavity. So the uterus is going to move down with that fetal head, and this is where lightening occurs. It causes some leg cramps. It can cause increased pelvic pressure, increased urinary pressure, and urinary frequency, because remember that baby's kind of sitting down further down in the pelvic inlet and putting that pressure on the bladder. Mom might have some increased vaginal secretions, some venous stasis. Braxton Hicks contractions. These are irregular contractions. They can happen anywhere from 10 to 20 minutes. And then mom will have increased discomfort. The contractions usually go through the abdomen and groin. But, especially for the new mom, somebody who's never had a baby, they might feel like it's true labor. So our bodies are amazing, and, this is kind of getting mom ready for this is what real labor is going to be like. But the difference between like a Braxton Hicks false labor and true labor is that these contractions don't cause dilation or effacement. So the cervical changes. So when labor is coming up, impending labor, the cervix is going to thin. It's going to become soft and stretchy. We talked about effacement, and this is the process of that change. So the cervix is ready for effacement. The bloody shoal. This is so when a woman is pregnant, the cervix has that barrier. It's this mucus plug that keeps the baby safe throughout pregnancy. And when that cervix is going through that change and that effacement, what's going to happen is this plug is going to kind of let loose, and the woman is going to have a blood-tinged mucus that just comes out. And this means that labor is going to happen within 24 to 48 hours. Rupture of membranes. So the woman can have spontaneous rupture of membranes, or this can be done by the physician. The ruptured membranes, what comes out should be the amniotic fluid, and it should be odorless and clear. If it comes out yellow or green, that could indicate that the fetus has passed meconium. It could be meconium stained fluid. or it could be some sort of infection. So we really have to monitor the fetus at that time. And this can be confused with urinary incontinence. So, you know, some women might feel like they've just accidentally urinated, because remember, that baby puts so much pressure on our bladders that urinary incontinence is pretty frequent in pregnancy. So the energy spurt, this is often called nesting. This is kind of our body's way of getting the woman ready for labor. You know, this is where most of the time the women are exhausted all throughout pregnancy, and then all of a sudden, you know, they're ready to paint their houses, clean it up, getting baby ready, getting the nursery ready for baby. Weight loss and GI disturbances. So mom can have some electrolyte shifts, and then they'll have kind of that reduction in the fluid retention. So right away, mom might see during this time up to a 3-pound weight loss, but this is fluids. Some women have nausea and vomiting. Not that most people have already suffered through it throughout pregnancy. They might get diarrhea, some indigestion. So, true labor, what does that look like? So again, I talked about the difference between the Braxton Hicks, where the cervix isn't dilating or effacing, but true labor is when that dilation and effacement starts. The contractions are going to be regular, and they're going to get worse. They're going to increase in frequency, duration, and intensity. The woman's going to feel it in her lower back, and it's going to radiate around to her abdomen. And the pain's going to get worse when she does activity like walking. So, figure 12-1 on 367 will show the differences between true and false labor. So again, that false labor, I talked about no cervical changes, and the contractions are just felt in the abdominal region. And when the woman stops walking or whatever activity she's doing, then the contractions stop. They don't increase in intensity. So childbirth settings and labor support. So upon admission, make sure that you're establishing a good, trusting, positive relationship. Get your admission data, do your baseline assessments, find out if the woman has a doula. That's kind of a support person that has supported the woman throughout their pregnancy. So that first stage of labor. So this is known as a stage of dilation. The woman's going to have some contractions and with dilation. This has 3 different phases. There is the latent phase, and this is where the woman will have labor pains. They usually describe it as kind of like some intense menstrual cramping with lower back pain. At this point in time, contractions are about 5 minutes apart, and this is early dilation, so 0 to 3 centimeters. Then they'll head into the active phase. This is where they're 4 to 7 centimeters, but the contractions are more frequent. They're now going every 3 to 5 minutes, and they last longer. And the multi-paras, the women who have had more babies, will progress quicker because they're cervix dilates at 1.5 centimeters an hour versus a woman who has not had a baby, hers goes a little bit slower. So you're gonna, you're gonna pretty much count on the multi-paras delivering quicker if you're taking care of multiple women in labor. The transition phase, this is the most intense. The contractions are every 2 to 3 minutes. They're lasting 60 seconds to 90 seconds. And this is when the cervix is dilated from 8 to 10 centimeters. You can use a tool called Friedman's curve, and that's a tool for you, so you can help identify whether the labor is progressing normally. Every labor is different, and for some it's hours and hours, and for others it goes quickly. So nursing care, make sure that you're doing that ongoing assessment. You're going to want to manage the discomfort and anxiety. Especially for these first-time moms, this is a scary, scary experience. Or for those who've had terrible experiences with labor. It's your job to be that patient advocate and let them know what's going to happen, and be honest about it. Do not lie and tell them that the pain is going to get better, that it's not going to hurt. So labor support, the presence. Sometimes it's just really comforting and reassuring to have somebody there, and especially, a nurse. If you work in OB and you know what's going on, it's nice to have somebody there. So make sure that you're comforting, that you're meeting those physical needs, that you're promoting physical comfort. So help the woman get in, comforting position. So sometimes sitting in a chair or reclining or lying on their side helps. The left side is the best side to lay on, because then there's no compression or pressure on that inferior vena cava. So that therefore the uteroplacental blood flow is better. So the environment, make the environment nice. Sometimes it's nice to keep it cooler in the room. But make sure it's not so cold that when baby comes out, baby becomes hypothermic. So make sure that mom has emptied her bladder. And that you're keeping mom clean. Mom is exhausted, tired, and make sure that you're changing those pads, you're changing the gown, and especially if they're still kind of leaking some of that amniotic fluid, they don't want to be dirty. Do some relaxation. Find out if mom has done any like Lamaze classes, and go through some of those techniques with her. Sometimes it's nice to have music. Just find out what the patient's preferences are. So, fetal assessment. So again, you want to identify the fetal position. There's a few different ways you can. You could do Leopold's maneuvers, and that's just doing abdominal palpation. You're going to find the location of where baby's fetal heart rate is best heard. You can use vaginal ultrasound or vaginal examination and ultrasound. They usually only use ultrasound when the physician can't find where the fetus is at. So you're going to want to get an assessment of the fetus's heart rate. The fetal heart tones are best heard when over the fetal back when the fetus is in that flex position. You're going to assess for variability, accelerations, and decelerations. So variability is the fluctuation in the fetal heart rate. Finding out how the pattern is changing, if it's irregular, if variability is adequate, that means that the fetus is adequately oxygenated. An acceleration is where there's an increase of the fetal heart rate 15 beats per minute above the fetal heart baseline, and it usually lasts for at least 15 to 30 seconds. This is a sign that baby's doing pretty good. But these accelerations need to accompany fetal movement. So, when it makes sense when baby's moving around more that his heart rate should be higher. When contractions occur, accelerations should occur as well. Decelerations, these are where there's a decrease in fetal heart rate below the baseline. They can be classified as early, variable, or late. Early is where there's a deceleration when mom's at that peak of that contraction. So usually this is pretty commonly seen in active labor. This is considered benign. It's usually not a big deal as long as it's well tolerated by the fetus. It's usually not a big deal when the baby's doing okay. Variable decelerations is where the decels are variable in their onset, frequency, duration, and intensity. Usually this is, it goes down 15 beats per minute or more, lasting at least 15 seconds, and then it returns to baseline. Again, because it's variable, it's not correlating with those uterine contractions, and usually this is associated with an umbilical cord compression. It could lead to nuchal cord, where the cord is wrapped around baby's neck, and that's an emergency. But you're going to notice that these are more severe decelerations. So if they're late decelerations, it's going to mirror the contraction, but the deceleration it'll have a late onset, and it will begin around the peak of contraction. So this isn't good either because there's a decrease in the blood flow. So baby is at risk for hypoxia. You need to make sure that you report this right away, that you're right away changing mom's position, so putting mom on that left side, because that's going to increase that blood flow, because that compression is not going to be on the inferior vena cava. And then if mom has oxytocin going to stimulate labor, you're going to stop that oxytocin. You're going to increase those IV fluids and get some oxygen on mom. So, interpretation of fetal heart rate tracings. So again, you want to consider the contraction. Look at the contraction, the frequency, the intensity, where mom is in her labor, her history, any conditions she has. Figure out if it's a reassuring or non-reassuring. If it's non-reassuring, that's like those late decels. Baby might have some tachycardia, and the variability might be absent. We talked about correction of that problem, making sure you get mom onto her left side right away. And then stopping oxytocin, amping up those IV fluids, and getting oxygen on mom. So it's kind of getting ahead of myself with the decels. Like I said, if it's early, no action. If it's late and variable, it needs to be treated. So that second stage of labor, this mom's going to get this urge to push. We want to promote effective pushing. When the woman has that urge to push is when she should push. But we talked about like different medications, so like different anesthesias can make it where the woman doesn't feel and doesn't have that urge to push. So she might need some coaching. So really, again, you're going to want to delay that pushing until the woman feels the urge. There is two methods of pushing. There's the closed glottis and then the open glottis. The closed glottis is where it's direct pushing, the traditional method where women are encouraged to begin pushing when they have full cervical dilation, regardless if they have that urge to bear down or not. The open glottis, this is when the woman is encouraged to hold her breath for 5 to 6 seconds during pushing, and then take several breaths in between each bearing down effort. The women are really encouraged to exhale through that bearing down attempt. But the intermittent pushing between the breaths really reduce the risk of perineal trauma. So preparing for birth. So what's going to happen is the perineum's going to bulge and the rectum's going to bulge. The perineum's going to become flat and thin. You're going to have that increase of that bloody show, and the labia is going to begin to separate. When birth is imminent, crowning will occur. The mom is going to get kind of a burning sensation, that intense pressure in the rectum. Mom may need an episiotomy, and this is a surgical incision that's going to that they make on the perineum, And what it does is it enlarges that vaginal opening. The problem with the episiotomy is there's risk with, well, there's trauma, it's risk of infection, but, you know, especially if mom doesn't have, you know, a very, very big vaginal opening, an episiotomy might be necessary. So the cardinal movements of birth. This is the mechanisms of labor, and this is how baby will pass through the birthing canal, and the positional changes baby will make that's required to facilitate birth. So there's 4 different movements. So descent is where the head goes into the pelvis. Flexion is where the head descends and then comes in contact with that soft tissue of the pelvis. During the flexion stage, usually the fetal chin will go downward into their chest, and that allows for the smallest fetal diameter to go through that pelvis. And then what's going to happen is there's going to be an internal rotation where, you know, so baby's head's starting to come out, and then it has to rotate. Then extension, where the head passes through the symphysis pubis, and it's right on the pelvic floor. And then what happens after that is, those are the movements with the head, and then restitution will occur, and that's where the shoulders then will enter the pelvis. So baby's head is already out, the shoulders are right there, and then the shoulders will have to turn with this external rotation, and expulsion, where baby's body fully comes out. So after this, cord clamping will occur. It's really controversial on when to clamp the cord. But it's all in positioning of the baby. So sometimes the physicians will choose to delay the cord clamping and hold baby below the placenta, so then some more blood will transfer from the placenta to the newborn. So it's been thought that you know, this can reduce any iron deficiencies in the infant, but I talked about in my previous podcast that you know, when more blood gets to baby, they're going to have that more red blood cells, so they'll have that polycythemia, and that can increase their risk for jaundice. So your job is to inspect the cord, make sure there's 2 arteries and 1 vein, and then they'll collect a cord blood sample for the lab to analyze. So some possible nursing diagnoses: pain, anxiety, fatigue, knowledge deficit, risk for infection, impaired fetal gas exchange. So the 3rd and 4th stages, this is where there's immediate care of the newborn. The placenta, you're going to deliver that placenta right after that. You're going to monitor baby, assist mom, and try to get that bonding to occur. So that 3rd stage, so you're going to get that gush of blood. You're going to see that gush of blood from the vagina. the lengthening and protrusion of the cord. So nursing care, you want to observe for signs that the placenta has separated. So the woman might need to push to get that placenta delivered. If it's been 30 minutes or longer and you can't get that placenta out, the placenta is considered to be retained. Sometimes Pitocin can be administered to try to help deliver that placenta because these stimulate uterine contractions. Because it stimulates that uterine contractions, it can reduce the risk of bleeding. And again, immediate care of the newborn. I talked about that in one of my other podcasts, making sure that the airway is cleared, that you're keeping baby warm, doing that APGAR score, doing that identification. When the placenta has been delivered, make sure that the physician will look at the placenta to make sure that it's all intact. You're going to monitor the uterus. If it's boggy and soft, you want to massage it to see if it gets any firmer. You want to assess the lochia, do INO, vital signs, put some blankets on mom and baby. Mom's going to be shivering. You want to promote comfort. You want to watch for hypotension, tachycardia, excessive bleeding, and then watch the uterus.